Welcome to Session 4, Addressing Behavioral Health Needs with a Trauma-Informed Lens. My name is Nicole Weaver, and I am the Trauma-Informed Care Manager for the Department of Family and Protective Services. I am also a member of the SCTIC. Our next speakers are Judge Delia Gonzalez, Dr. Mohsin Khan, Nathan Hoover, and Dr. Valerie Smith. You can review their bios under the same tab as the Zoom link. We will save some time at the end of the session for questions, but please feel free to submit questions during the presentation under the Q&A feature. Now I will turn it over to the speakers.
Thank you, Nicole. My name is Delia Gonzalez. I'm the Associate Judge of the Dallas County Child Protection and Permanency Court, and I have the pleasure of providing the introduction this morning. Some things that I think that we as a judiciary should always remember when we're talking about youth and trauma-informed care is that we have to have the mindset that all youth that are in care have been traumatized, and remember that the very act of being removed from their normal is traumatizing to them. And so once we start with that baseline, I think we have a better ability to find out and look into what is going on with the youth's behavior and start asking the questions, why? Why is their behavior a certain way? What is going on? And in order to do that, we have to come together and collaborate on ideas for that specific youth. Believing that we can cookie cutter our youth in care and what is going on with them is not the trauma-informed way. We also, I think as a judiciary, should have conversations with the youth to find out what is going on with them so that we can understand what their perspectives are, what their feelings are, what is happening to them from their mindset and their perspective so that we can bring that trauma-informed approach to them. And as a judge, I must always remember that if the youth is receiving psychotropic medication, there must be a finding that the youth is given or provided the appropriate non-pharmacological interventions, psychosocial therapies, or behavioral strategies first to meet the child's needs, or that the youth has been seen by the prescribing physician, physician's assistant, or advanced practice nurse at least once every 90 days. Then and only then can we ensure that the children are receiving appropriate medication as directed. In my court, we always attempt to look for non-pharmacological interventions first, as we believe that that is the best practice for trauma-informed care. When we utilize trauma-informed practices, it is amazing the things that we see our youth can do. It is amazing to see the changes and the turns that youth can make with regards to their behavior, academics, and ultimately their permanency goals. Nathan?
Thanks, Judge. So just real quickly, I'm going to hit a few of these highlights. This slide deck will be available to all of you if it's not already in your materials. So don't worry if we don't hit every point, you'll have a chance to reference back to it. But when we really start talking trauma and having that lens that you're looking at a child through or a youth through, one of the first shifts is this idea of going from the what's wrong with you to what happened to you. And really that stance changing is one of the biggest things you can do because you're already setting your mind in a different way. Because when we say what's wrong with you, then we tend to put a lot of the blame on the kid for everything that's going on, as well as have a mindset that, you know, something is broken that needs to be fixed. And if we don't see it fixed, then there's some fundamental failure. When we start to say what happened to you, we begin to get a better understanding of letting that child tell us their story, beginning to understand that there have been a lot of factors that have influenced how they got to where they are today. And it changes the trajectory of treatment as well. Just jumping down, you know, don't assume that, you know, a child is just behaving badly, right? All behavior has meaning. So they are trying to tell you something, even if they don't fully understand how to put it into words. We see this especially with younger kids and even those who their development may be a little slowed. And then, you know, a couple of other things is that you do want to know that two kids can go through a very similar event and have two very different outcomes. So we don't want to begin to think that it's a one size fits all. And hey, if Jimmy over here is not doing that, then why is Janie? You know, it's just unique to each child. Last point there, of course, and we'll talk more about this later on, but just the idea that you do want to get professional help involved and be able to help address those symptoms as well as the underlying trauma that's gone on and do it in a way that's most effective. And with that, Dr. Khan, I'm gonna shift over to you.
So I'm also Khan. I'm a child and adolescent psychiatrist. I'm actually working in Dallas, both in Plano and Dallas location. And I'm going to start off with some challenges in terms of what I perceive as barriers when we are doing initial assessment, then kind of go and lead into more trauma-informed assessment that I hope that you guys really find helpful. But one of the biggest challenges that we find when we're doing our initial assessment is a lack of information, actually. A lot of times it is historical information. We don't really have a lot of information about child's upbringing in terms of their developmental milestones, their academics, their social milestones, what sort of treatments they've received in the past, if they have received any treatments, first of all, and whether they have been effective or not also. In addition, of course, we have at times we have uncooperative parents, which can eventually lead to caseworkers not having all the information. And all of that can definitely provide a lot of challenges when we're doing our initial assessment. The other thing that really makes it complicated is the history of trauma. You guys are already see. Have a lot of neglect, a lot of abuse, whether it's physical or sexual, along with a lot of challenges in terms of attachment, parental psychopathology, food insecurity, among other things. And then placement disruptions also complicates decision-making as well for us too. But all of that being said, I think accurate assessment is still the key to effective treatment, especially evidence-based treatment. So the other challenges that I have noticed, this is more observation than anything else, is that a lot of times kids are actually not directly asked about trauma and abuse. They have also been coached from adults in their lives to not talk about it. They have been blamed for being a victim. And then in addition to that, more importantly, because of not being believed initially, they don't want to talk about it anymore. Furthermore, avoiding painful emotions and unpleasant thoughts related to trauma, that itself is very important to recognize in this population, because that could be a kind of an identifying symptom for PTSD as well, post-traumatic stress disorder. In addition, they're not being aware that their bad behavior is actually related to their trauma. And lastly, they're also afraid to disclose any sort of information because they feel like they're going to end up in a hospital. So in terms of the trauma-informed assessment, as a physician, I'm definitely incorporating this a lot more than I had in the past, but I feel like this is something that should be done from all of our teams, because I think the more information we have, the better we can serve these kids. And all of that starts off by letting them know kind of what the plan is in terms of the assessments. And that definitely is dependent on the role. So you definitely want to generalize. So as an example, I'm going to ask you a lot of questions that I ask everyone, because most of us experience these things. So in a sense, you're also letting them know what you're going to do, and then at the same time, normalizing things for them too. In addition to that, you can as an example, I'll let the teens know, like, we're dealing with depression, self-harm, substance use, telling me that part of it is about dealing with bad memories or painful feelings from things that have happened in the past. A lot of times those memories and feelings are hard to talk about. So you're kind of normalizing them. And then of course, validating their emotions afterwards as well. That must be so hard and frustrating. It must be so confusing for you, that everything that you've been going with. And then explaining. A lot of times what ends up happening is that the child is asked a lot of questions without any sort of transitions. I always advocate for the kids to be aware of what they're going to be asked for initially. So letting them know, and you can let them know, like, I ask these questions because I want to make sure that you're safe. I also ask because I want to make sure that it happens to a lot of people. And I'm trying to understand what is behind the behavior too. So all of these are very important, but one thing to always keep in mind is that what sort of rapport do you have with the child as well? So while these are great tools to utilize, try to initiate your conversation with the child by getting to know them a little bit and really understand kind of their weaknesses as well as their strengths. And that can really help you build a rapport with the child and really get a lot of this in-depth information as well. So always start generally and then specifically. Keep in mind that yes, we have a lot of these kids who've been traumatized because of their background, but there are other traumatic factors that could be accidents, violence, natural disasters. They may have been bullied in the past as well. So how do we get all of that information? So usually I will personally start off with more general questions and then get more specific. So have you been through anything very scary? Bullying, violence, accident? Have you lost anyone close to you? Has anyone ever hit you and harmed you in any way? Who yells or fights the most in your house? Do they ever get physical? So if you notice, like the questions are definitely general, but you can definitely get into specifics of that as well. And we haven't even touched kind of the physical abuse or the sexual abuse component. This can also give you a lot of information about what sort of consequences or punishments were used in the home setting and how they can have an impact when they're changing placements too. The second last question on the slide in particular, I really like that one, especially for our adolescents who are really involved in a lot of like relationships. And that can eventually, for some kids, that can turn into risk-taking behavior as well. So you mentioned about being in a relationship. Does he or she treat you well? Has he ever threatened you, hit you, made you do anything sexually that you didn't want to do? I think that's very important to ask these kids. This is a vulnerable population that we need to be focusing on some of these things, some of these issues as well. And of course, the last one being, have you ever done sexual things in exchange for money, drugs, and places to stay? So ask often. Don't feel like just because you've asked them one time that and taking it at face value. So definitely over time, if you're going to meet that child over multiple visits, multiple assessment, definitely ask them often. Show respect, show empathy. I'm sorry you had to go through that. It is so unfair you had to go through that. Definitely respect their avoidance at the same time as well. It makes sense that you've been trying not to think about this. It sounds like it's just too hard to think about at times. And then respecting the resiliency. You have been through so much. How have you been able to handle all of this? I think that's very important in terms of recognizing their strengths as well, because we really want to build on those things and really move them in the right direction moving forward. And then lastly, definitely know your limits and then praising them a lot as well during your conversations with the kids. I know it's hard to talk about this. You're very strong for doing so, and I'm very grateful that you're sharing it with me. So in terms of the trauma-related symptoms, as I said, like it definitely complicates the diagnosis and the history taking as well. So if you think about it, in a young child, this trauma-related symptoms can present like tantrums, impulsive behaviors, aggression, destruction, control-seeking behaviors, attachment difficulties, exaggerated behaviors, and these are just some examples. So if you imagine that the comorbidity of kids who have been traumatized with depression, anxiety, ADHD, anxiety that tends to be very high as well, it can be a challenge if you're not taking trauma into perspective, and how that can lead to kind of an inappropriate, not necessarily inappropriate, but incorrect treatment algorithm per se. So in terms of the evidence-based treatment, I know Nathan is going to specifically talk about therapies directly, but one thing I do want to make a note of is when you have kids who are who are struggling with behaviors, definitely think about, okay, what sort of therapy they're getting, first of all. Is it just skills therapy? Is it play therapy? Is it music? And what sort of therapies? And really deciding, okay, are these the evidence-based treatments that should be recommended to this child at this point in time? And that holds as well. If they are struggling with behaviors, should we recommend more specific form of behavioral therapy with the parent management training as well? Because a lot of these parents need additional support to be able to work with these kids and make sure that we can provide them routine and structure and still be able to build rapport with them. At the same lines, like as an example, play therapy. If we have a child who's 10 or 11 or 12 years old, is the play therapy really the ideal therapy for the child to be in? Because that therapy is usually indicated for a lot younger kids. I have some slides on the medications as well, but I'm very open about talking about both therapy and medications at the end. So feel free to let me know. I know Nathan is going to talk a little bit more about the therapies right now.
All right, thank you, Dr. Khan. And so as we look at this slide on the evidence-based therapy models, these are 5 in particular that for Superior we've identified as part of an alternative payment method, because we've recognized these are all scoring as a 1 on a scale of 1 to 5, with 1 being the best rating, meaning they're the most evidence-based. One thing to piggyback off of what Dr. Khan said, it's really important to understand that the therapy is going to depend on the child and depend on their age and their developmental state and several other factors that you want to take into account. And so part of the reason of having at least 5 here is just to give you some variance and some variety as far as being able to choose what's most effective given the child's situation. So let me just quickly hit a couple of key things here. For those younger kids, you see at the bottom, parent-child interaction therapy. That really is about that parent-child interaction, right? No big surprise based on the name. But if we think about where a child's at developmentally, it's so much focused on what is their interaction with the adults in their world. And so that's where the focus becomes. As a child grows, you see some other options come into play. So when you look at things like trauma-focused CBT, obviously that's available for children and adolescents. Knowing the STAR Health population and knowing the ages it ranges through, if a kid's in extended foster care or in their later teen years, there are several of these like EMDR or prolonged exposure, or CBT, things like that really may be more appropriate based on where that child or adolescent, young adult is. So you just want to think through which approach you're looking for. Real quickly, just from a health plan perspective with Superior, we do have identification of which of our therapists have which of these certifications. So if you're having trouble tracking that down and need some support, we're absolutely here to help do that. Lastly, on trust-based relational intervention, I know TBR has gained a lot of momentum in Texas. It's currently rated as a promising practice, and we definitely hope to see it move to a level 1 in the near future. A couple of things to understand with TBRI. It's a little different in that the other modalities are really therapy setting type modalities. TBRI also has a really strong caregiver component. So you can see that implemented in settings within, group home, RTC, even within just a traditional foster placement or kinship placement. But it has a lot of the skill focuses on how the caregiver is going to work with the given child. So just wanted to clarify that piece. And with that, let's kick it back over.
This is just a resource slide for you guys in case if you ever want to look at kind of the indications for the medications. By all means, as I put down at the bottom, it is very generic. They can be used for a lot of other reasons as well, but this should get you started in terms of making sure that is this really the evidence-based treatment for the child or not.
Nathan, I think we lost you. Are you guys hearing Nathan?
Oh, thanks, Nicole.
Oh, yeah.
Sorry about that. The dreaded forgot to come off mute. Thank you, Nicole. So psychotropic medication utilization review, PMUR. This is something available to all kids in Star Health. One of the founding principles of when the state created managed care and had Star Health come in was concern about medication, and specifically medication for kids who are in foster care. And so this program is really meant to help ensure that kids are on the least restrictive amount of medication to gain the needed clinical benefit. And so it looks at the medication regimen. It works with the providers to figure out what's appropriate. We have a child board certified, trauma board certified psychiatrists who are involved in this process to talk to the prescribers and get an idea of what's going on. So you have a link there to what those parameters are. It's also really important that it's in bold at the bottom, but just want to highlight it. As a judge, you can request a PMR for any child enrolled in Star Health. So if you have concerns about what their medication regimen looks like, you always have the right to do that. We certainly have several judges on a regular basis who do so. So please do take advantage of that tool. And with that, Dr. Smith, we'll kick it to you.
Thanks so much. I am a general pediatrician in Tyler, Texas. My practice focuses on caring for children in foster care, and I also serve as a consultant to Superior as in their Foster Care Center of Excellence program. So I wanted to take the opportunity today to talk through what our transformation has looked like in a clinic setting as far as implementing trauma-informed care for our patients and how I think that can overlap into what a trauma-informed courtroom can look like. Because really the principles are very much the same. The first principle that our clinic decided to implement that I really encourage all organizations who are working, especially with children in the child welfare system, but kind of collectively with children these days, because we know that there are many, many children who've experienced trauma who are not in the child welfare system, who aren't necessarily in foster care, right? Is taking that kind of universal precaution. So instead of identifying, oh, this is a child that I know has experienced trauma, and so I'm going to apply these principles to how I interact with this child, or their people or their caregivers, is really to think about all children are likely that you're encountering in the court system are likely to have encountered or to have experienced trauma. And so using these techniques and these trauma-informed principles kind of universally. The other thing that I think is really key there is that we're doing a better and better job, I think, every day as a state in creating trauma-informed systems for children. Our educators are learning about trauma-informed care and are now required, right, in school systems to learn about trauma. You guys are here learning about it from a court perspective. I think it's really important that we remember that their caregivers likely have experienced significant trauma too. And we mentioned before, Dr. Khan mentioned that entering care is traumatic for a child no matter what, right? Because they've been removed from one setting and placed into another. I would counter also that having a child removed is a traumatic experience for an adult, period, end of story, regardless of what events led up to that experience. And so recognizing that not just the children, but the caregivers that you're working with have also likely had a really significant traumatic history. And then from a clinic perspective, we had to really acknowledge that medical settings just in and of themselves can be traumatic, right? We do procedures, we draw blood, we're a bunch of strangers interacting with people. And so that medical settings in themselves can create trauma. And I'd like for you all to consider that court settings can be very similar in that respect. That a child entering a court setting where they may not be familiar with what is happening, where there are rules that they don't necessarily know or aren't familiar with, as far as when you speak and who speaks to you and how you're spoken to, even when you stand up and when you sit down, all of those pieces can be overwhelming often to children. And so thinking about what those creating systems that acknowledge that. And I know that many of our children who are going through the system have CASA workers to help them with some of those experiences. But just knowing that the court system in itself can be traumatic. And so then I use a framework when I talk to other pediatricians and healthcare providers about trauma-informed clinics, but I think it's also helpful to apply to trauma-informed courtrooms and court settings as well. And it's the 3 Ps. So the first one is the physical space. So as an example, in my clinic, when we began looking at trauma-informed care and how to implement it, we actually had a couple of people come through our clinic, and then we interviewed them afterwards and asked them about we called them secret shoppers because my staff didn't know who they were on the front end, right? But we asked them about their experiences. And one of the things that several of the kids mentioned were that we had a solid door to our clinic and they didn't know it was on the other side. They knew they were going to the doctor, and that was scary enough. And they really just weren't sure what was going to happen on the other side. And so that opening of the door was kind of a scary thing for them. And so that actually led us to create a door that has a glass window. I know that particular example may not be practical for courtrooms, but thinking about how your space is laid out and how a child might be interacting with it or a traumatized adult might interact with it. And that may include distance between people. It may include barriers where it's clear, okay, these people belong on one side, these people belong on another side. That makes it feel very adversarial from the very beginning. That may partly involve like the height at which the judge is at compared to the especially for a child who's very small to start with, like that feeling and how that power dynamic might feel. And are there things you can do within your physical space that might reduce the trauma symptoms that a patient might, or a child might experience, or a caregiver might experience when they're in that? The next P is it's actually 2 Ps, the policies and procedures. And the policies and procedures, I think, are really helpful because those are the things that are baked into how your system runs that you don't even think about when you're a part of the system. It's how your docket is run. It's how your calendar is run, how your schedule goes during the day. It's what happens as people are transitioning from one case to another. But those things may be very uncomfortable and may be very difficult for families who have experienced trauma. I think about many of our caregivers who are working very hard to keep a job because that's part of the requirement for their child plan in order to be able to regain custody of their children, but then are given a day to appear in court where they have to take an entire day off work because they don't have a specific time. So thinking about ways, and I will say this is one place where COVID has opened up doors for us to allow people to remotely come in so they don't have to necessarily have an entire day of their of their life that might have consequences for missing work or other experiences that actually negatively harm their case. So thinking about what policies and procedures your courtroom has that may be difficult for families who are struggling with access to transportation, who are struggling with employment instability to access, and how you can modify those potentially. So for us, it had to do with adjusting our late time procedures and our no-show policies, right, in the medical setting. And then the last one is personnel. And I know you all have talked today about many aspects of trauma and how to interact with children who have undergone trauma, but looking at ways that those personal interactions, the people within your clinic can be educated on trauma and how to provide trauma-informed care. So some of those examples for us in the clinic involve providing choices for children and caregivers, as simple as like, do you want your blood pressure taken on your right arm or your left arm? Or I need to draw blood from you today. Would you rather I use your finger or would you rather I use the spot under your elbow? Fancy medical term for that's your antecubital fossa, but no kids know that. So, right, thinking about those, and even just thinking about that language, I would not use the term antecubital fossa with a kid because they would have no idea what that means. But if I point to the area on their elbow, they know exactly where I'm talking about, and they can help make those choices when applicable. And then the other piece is amplifying strengths. So when children and caregivers are together and you notice a caregiver providing reassurance to a child, when you notice a child looking to their caregiver for, or their parent for reassurance or for kind of comfort, identifying those things and recognizing that bond can be a really, really helpful tool in settings where families are often uncomfortable. And then I think the last thing I would leave you all with as we transitioned to some case conversations is that no one system has all the solutions to help support traumatized families and traumatized children, but also no one system has all of the responsibility either. And so recognizing where, for example, within healthcare, there are opportunities for us to help support the work you all are doing, and vice versa, looking at where, in my experience, looking at where child welfare can help fill in some of that gap and provide some resources for families. So knowing those resources within your community and then relying on them, working with, again, continuing to work with the education system, recognizing that our children who are in foster care or who are involved in the child welfare system are not just in the child welfare system. They are interacting with multiple other systems. And so increasing each of those systems in a trauma-informed manner.
Thank you, Dr. Smith. So at this time, we're going to go and talk and have a discussion with regards to some real cases and real options that have actually happened in my court. And I'm going to give each of the panelists an opportunity to respond to the situation. And then ultimately, I will talk about what the court's rulings were with regards to the specific case study. So the first one that we have is a 17-year-old that's in a residential treatment center. And this particular youth had been in 21 homes since her time in foster care. She's been on 7 different medications for the diagnosis of depression, anxiety, and oppositional defiant disorder. I think we all know that's a familiar one. The residential treatment center said that she was placed in previously had closed down and was transferred to another residential treatment center. She was evaluated by another psychiatrist, and the same medication was continued, and sleep medication was also added. Dr. Smith, how would you first handle this?
This is a very familiar experience to me. Part of my work with children in foster care is serving as the primary medical home for several residential treatment centers. And so one of the things that just struck me immediately was how not unique this situation is, as far as the red flags of just having a huge number of placements and placement disruption, as well as multiple psychotropic medications. So as a general pediatrician, when someone comes to me on multiple medications, psychotropic medications, it's usually not my purview to start messing with those medications or changing those, right? Changing those medications. We're gonna let Dr. Cont talk about how he would approach that piece, except it is my job as the general pediatrician to look at the whole child. So to communicate with that psychiatrist who is seeing that child about concerns that I have regarding that. Also, just as you all as judges can request a PMR review, I can request one as well. And I've done that from time to time, so that might be an option for a patient like this here. But the biggest thing I can do as a general pediatrician here is look at what this child is not getting. So there's a lot in here about the medications the child's receiving, but what I don't see in this case study is what kind of therapies they're using and what therapeutic environment they're in. And so working with their new placement to ensure that they have those behavioral health services is really, I think, my primary responsibility in this particular child. The other thing that I think, as someone who's charged with looking at the whole child and considering medical and psychiatric issues at the same time, would also be looking at and asking the child a lot of questions about any symptoms they're having that may be due to the medications that they're on, and so that we can then kind of draw the attention to the fact that we're seeing physical medical issues that may be related to the psychiatric medications. And then I'm going to turn it over to Dr. Khan to tell us what the psychiatrist should.
So yes, so I completely agree. This is not an unusual case for me either. What concerns me, a few things that concern me over here is that she's been in 21 different homes. So what that makes me think, okay, what sort of, first of all, what sort of trauma had she gone through and what sort of treatment has she received during this time period? And secondly, was it even evidence-based treatment? Specifically in terms of the medications, what concerns me is that she's on 7 different medications at an RTC, and once she went to another RTC, they continue the same medication, added a sleep medication as well. It is not unusual for me to see a lot of the kids who are on 7 different medications, and once I have done at least my assessment, I really question as to why they need to be on that many medications in the first place. A lot of the medications, at times when I'm reviewing them, I try to think about what's the evidence base behind them, and is the child having any symptoms that could be mitigated with the need for the medication at the time. So if I'm seeing a medication that is not needed or doesn't have a lot of evidence, I try to stop and taper those medications pretty quickly within 1 or 2 visits, actually. And that's assuming the patient has been in that same placement for some time, because I want to make sure the caregiver knows the child as well. The other thing that, in regards to the sleeping medication, now, if this was associated with just the move by itself, I would say it's not necessary to add a medication right away, because when you change placements, or if there is an additional person in the home, caregiver settings, household settings, that can be a disruption for the child. So let them kind of get adjusted to that first, and then reassess the need for the sleeping medication. And lastly, could the 7 medications that the child was on, could those medications be activating the child as well? What I mean by that is that could it make them more difficult to go to sleep? There are certain side effects of the medications. And then in terms of the medications also, I feel like this is one of the things that I think as a team we can definitely do better in, is when the child gets placed on the medication, is there any sort of documentation that's done from caregiver's perspective or from CPS or provider's perspective in terms of was the medication even helpful or not? And then make sure that that is carried over to the next provider, because if there is a gap in the history, if the child is only on a minimum amount of medication in terms of knowing if it's helpful or not, I'm probably going to end up raising it, assuming I feel like, yes, there are significant challenges for the child and he will benefit from the medication. Whereas if I feel like, no, this is not something that the child should be on, I'll probably go ahead and stop it. ODD in particular is a behavioral disorder. It is not a disorder that you treat with medications. So that is the biggest thing. So if you have a child who's on who's being diagnosed with ODD and gets placed on a medication, I would really question that. That is not evidence-based by any means. On the same note, I see a lot of kids who get diagnosed with ADHD and they are not on even evidence-based medications for ADHD per se, which can be a huge mimicker for the underlying trauma itself. Nathan?
All right. Well, yeah, not unlike you, both of you. I've definitely seen this scenario happen several times. And so let's just do a little math. Let's say, just for argument's sake, she came in when she was 7. That means she's been averaging 2 placements a year. So, first question I would throw back to everyone is, how well would you do if you had changed your placement twice a year for the last 10 years, right? So I think we need to be, right off the bat, be realistic about what she's been through. Here she is at 17. She's gone through yet another change. Hard to say what led to the different changes. The RTC being closed, obviously out of her control, but it was yet one more change, and all of the different traumas that go with that. So a couple of different things we would do on the Star Health end. one, anytime there's a placement change, we're going to reevaluate and do a new health risk assessment to figure out if anything's new. And so that's one of the first steps, and figure out what type of support's needed. With her being in an RTC, we would want to offer one of our service managers, one of our licensed staff, to help support what's going on with her. Also with that age, I mean, she's primed for the transitioning youth program, because as you guys often know, if a kid, 17, they turn 18 and they're walking out of the door. So you go from an RTC that's super structured to no structure. That's not a very good recipe for success. So one of the things we would be looking to implement would be that transitioning youth program. And that'd be a combination of working with her and who's identified as the lead caregiver in this case. Oftentimes when RTCs are involved, we're going to work with some of those lead case managers and different therapy staff that are on site, but also, of course, involving the CPS worker about what is her plan, that sort of thing. Because again, with everything that's gone on, you really want to start thinking forward. What is the plan going forward? If you've moved around that much, what type of support system does she have? Are there any people that have been consistent? Is there anyone she would want to lean on or have be a part of her planning going forward? So you're really beginning to, at 17, you really got to really drill down hard on what is this plan going forward and who's available to be a support for that. And she needs to have a very strong voice in that planning. She needs to be able to tell you who those people are, if there is someone she wants around, things of that nature. Because if you miss that, we're truly at the end of our period here with her, and this is our last period of time to make an impact for her. The other thing I would throw out there from a health plan perspective is when a child is changing placements, oftentimes we may have information that a PCP or pediatrician may not, the psychiatrist may not, things like that. So where there is a resource, we can reference like, hey, did you know, in addition to these medications, she's previously been on these other ones, or we've been able to tell which type of therapy she's been involved in. And we would absolutely want to identify a trauma-informed care therapist to plug in and make sure that piece happens for the remainder of her time. And of course, like I mentioned, PMUR before, this case seems very appropriate for a PMUR. And would want to look at that review overall and figure out if something could change. One trend that unfortunately we see often in foster care is that when children do change placements, more medications are added. Seldom are they taken away, right? So much like this case, right? So it always, like Dr. Kahn mentioned, Dr. Smith mentioned, you want to be able to get a good idea of what's going on with the child, and then look for what are those opportunities to reduce medications if possible. And Judge, let's turn it back to you to hear what really happened in this scenario.
Thank you all. So it's very interesting. The first thing that happened when I started talking, or when I saw this case, is I had the youth come to court because I wanted to talk to her and find out what's been going on with her. And 21 placements is a lot of placements for anybody in their entire life, much less a youth that's in care. And so, and just like you said, Dr. Smith, about having an area and a space that is comforting and that is not so traumatic and stressful. When kids come into my courtroom, there are stuffed animals everywhere. There are books all over the place. We have a waiting room. I call it the playroom, because there's a little basketball goal that kids can play. We shoot hoops with them. I shoot hoops with them. Some kids like to color. They do puzzles. There's snacks. We tried to make it as welcoming as possible, because I do know that it is stressful and traumatic for kids to come to court. And so she came to court, and immediately she grabbed onto a stuffed animal. And I said, it's yours. Keep it. And we started talking about all the things that were going on with her. And, when we had her court hearing, I ordered that she attend every court hearing, that she participate in every aspect of what is going on in her life. And of course, I did some of the things that were mentioned earlier. I requested a medication review because 7 medications seemed pretty, it's very common for our youth, unfortunately, but it is not what should be happening, I should say. I also noticed the ODD diagnosis, and as Dr. Kahn said, that is a behavioral issue. And so that was another reason why I saw it as a medication review as opposed to receiving psychotropic medication for that. I also had asked her, when's the last time you've had a counselor? Because if you're in so many different placements, it's hard to actually receive consistent counseling, B, establish any meaningful relationship with a counselor, and C, the time period that it actually takes for the services to start is probably more than 30 days, unfortunately. And so by then, is their next placement going on? And so I immediately ordered a trauma-informed therapist to help this youth out and ordered that services begin for her within 10 days from my court order. And guess what? It happened. And there have been times that I've had to reach out to Superior myself and say, this is what's going on. I've had to reach out to Nathan before saying, I need some help how to locate trauma-informed therapists in a particular youth's area. And the website is really helpful for me as a judge to understand different things that are going on. And that website also gave me the ability to see different options, different modalities of therapy for this youth. And so ultimately what happened is we transitioned the youth out of an RTC because again, she's going to be turning 18 soon. Too high of a structure to no structure was not going to work for her. That became very evident to me in my first meeting with her. I had a medication review set up for her. On a side note, we started looking for family again for her. And then we got her into a trauma-informed foster home with trauma-informed therapy. Her medication review came back. They recommended a change in medication. She went down to 2 medications and was given therapy as she was needed. And she was cooperative and she was wanting to engage and would come to court, and her head started to hang a little bit higher. Her schooling was better. She started passing her classes, and she ultimately transitioned into with family. But had we left it alone and just continued to let status quo happen, I could assure you that would not have been the same outcome. Nathan, case study 2. A 6-year-old boy in a foster home, and he was separated from his siblings and was reported by foster mom to not be sleeping at night. Foster mom also reported that he wasn't following directions or eating well, and he was crying a lot. Foster mom reports that this 6-year-old was yelling and at times hitting her and her spouse. This went on for about 2 weeks, and foster mom went to the psychiatric hospital, indicating to the hospital that the child was hitting adults and that he was a danger to others. He was in the hospital for 3 to 4 days and then further prescribed 4 medications to address ADHD and ODD as diagnosed by the hospital. Dr. Smith, how would you handle this situation?
So this case breaks my heart because it's entirely predictable, right? That a child who is separated from their parents and caregivers and their siblings, so any support structure that they know, is likely to have, again, we've already discussed, this is universally a traumatizing experience, is going to have behavioral symptoms. I think the challenge for some people is that behavioral symptoms can look very different. So some children are going to withdraw and become isolated and sullen and not communicate. Some people are going to lash out. Some kids are going to become hyper vigilant, where every single, like their anxiety, right? They worry about every single thing. And this kid actually is kind of exhibiting multiple pieces of those types of reactions that children can have to trauma. But it's entirely acceptable. It does make me, my first thing that as you shared these cases with us, is that I wondered what this foster mom had been received in the way of trauma-informed education, and what she understood about trauma and adjustment insomnia, as Dr. Khan was talking about in the previous case, because it seems as if it's likely that that's not the case here, right? That this was not a home where the foster parents had experience. I will tell you, one of the things as pediatricians that we have advocated for over the last several years is the need to see children when early in their course in foster care, kind of immediately after removal, as people now lovingly refer to it, the 3 and 30, or the 3-day medical exam. Which I know has created a lot of work for child welfare. But this is a family that if I had the opportunity to sit with that mom at day 3 and have a conversation about what to expect with this child and the trauma they've experienced and those symptoms over the next several days, we might not have ended up in the hospital, right, 2 weeks later, instead. And then the piece, I'm going to let Dr. Khan talk about the medication addition, which I will just say from a from a general pediatric perspective, this child is young, and these are clearly trauma-related symptoms. And so the idea that these diagnoses are then added into 4 medications on a child this young is very concerning to me.
So when I look at this case, a couple of things that I think about is the child is just removed from siblings, potentially from his bio home as well. And so Dr. Smith touched base on how traumatizing that can be for the child. In addition to that, don't forget the environment that he's coming from as well. That could have involved a lot of domestic violence, poor modeling, maybe lack of care at all, attachment issues, food insecurity once again. And when the child changes placement, if the parent or caregiver does not understand the complexity of trauma, you can actually end up triggering a lot of those prior symptoms as well. When I read this, sounds to me like foster mom was overwhelmed herself, and it sounds like there was a lot of negative interaction between the caregivers and the child, and that if they would just have been educated, I think it would have definitely have a different outcome moving forward. The other thing I was going to mention is that ending up in a hospital, I probably, if he needed additional treatment, I don't have full history on this one, but I would probably say that the intention should have been to try maybe outpatient, like day treatment programs or intensive outpatient programs rather than an inpatient, because in my opinion, even if you're seeking inpatient, unless it's absolutely needed, that can be a traumatizing experience as well for the child. In addition to that, you're also now changing another placement for the child in a quick interim, and then he's going to leave that inpatient hospital again within the next week or two, maybe potentially with the same family or a different family for that matter. So you've already moved this child now multiple times, re-traumatizing him multiple times as well. In terms of the ADHD, now, one thing to keep in mind is that ADHD is something that you typically diagnose when it's present in 2 separate settings. So I'm really curious to know what sort of information was provided by the family or the team members to the hospital, and how was he functioning at school really? Because if he was fine at school and most of the issues were happening at home, I wouldn't even say this is ADHD. I would really question that. Now, there are times when I have noticed that kids have a lot of support in the school system, and maybe those symptoms are not as obvious, but you may be able to pick them up in a clinical setting, but those are not as common. So that's the other thing that I would probably question in terms of the diagnosis itself.
Yeah, and I'll just round out the conversation here. Yeah, I think we all had a pretty similar reaction when you see a case like this. You know, anytime you get in a sibling separation, it's a real delicate issue, right? I think we've all seen cases where it was appropriate to have siblings go into different homes for the betterment of one or two of them, but it's also detrimental, right? You're always trying to balance the good with the bad, and so that's a hard situation anytime that happens. But anyone involved should absolutely expect there's going to be a reaction. So anytime you're separating siblings on top of already being in foster care, it can be a very challenging piece. And I know CPS does they do a thorough job and really work to try to make this work as much as possible. And sometimes there are limitations. I've seen some scenarios over the years working in foster care where siblings, when they did have to be removed, they were released in homes close to each other. So you still try to maintain that contact. So there's some pieces that you can try to put together, but long story short, this one went obviously really, really bad, worst case scenario type of thing. From a health plan piece, when we see a kid this young go inpatient, obviously it raises some red flags on our end too. And so we regularly review any kid that's in the hospital, especially in a psych hospital. We have clinical rounds with child psychiatrists talking through, what's going on and that sort of thing. So we would definitely be reviewing what was told to the hospital, or what was the hospital's understanding or justification for feeling like inpatient was the appropriate route. We would also have communication with the hospital about what are the options to have this child discharged. And like Dr. Khan said, can we look at even a partial hospitalization or IOP or some different programs that wouldn't be as intense? Because again, one of the things I've seen, once a kid goes to the hospital, of course, they're more likely to go back to the hospital. So if you can help stop that first admission from happening, you're setting them up for a much better route. Absolutely would be looking at a PMUR in this case. One of the things we've added just in the past years, we We have a couple of providers we're working with where if a child's coming out of the hospital and we have concerns about their medication regimen, like we absolutely would in this case, is the option to have a second opinion done via telehealth. So again, like Dr. Smith mentioned earlier, COVID's kind of opened up some of the telehealth options so that a child could potentially have those medications adjusted rather quickly. And again, to either a much lower amount of potentially even one medication for ADHD, if that's legitimate. In all likelihood in this case, I mean, I completely agree. This looks like trauma all day and night. And so I would not expect medications to be appropriate or be recommended. So those are some of the steps. I mentioned the health risk assessment anytime a child changes placements on the previous case. We also do a new one anytime a child discharges from a hospital, whether medical or psych. So again, we'd be reevaluating. And of course, the big piece is making sure they get a trauma-informed care therapist, right? So that, it's not just about what do we not want to do, but it's what are we going to do instead? And so getting them connected to a trauma-informed care therapist and doing that in a way that helps not only work with the child, but also, as Dr. Smith said, begin to educate the caregivers about what they should expect and what they're going to see and some of those things just for clarity. And Judge, I'll turn it back to you.
I'm going to interrupt real quick, actually, just to make one other comment related to that, that Nathan kind of sparked me to think about. I actually saw a child very similar to this at Reese Jones, where Dr. Khan practices, when I was spending some time training, and without the hospitalization piece. But what I had the opportunity to do was watch parent-child interaction therapy in real time. And this child and this particular setting would be like an ideal situation for parent-child interaction therapy to give that foster mom or the new caregiver, if they're changing placements, the tools to help manage this child's behavior.
Sorry.
Go ahead, Dr. Khan.
Well. So two thoughts also. So in terms of the PCIT, the parent-child interaction therapy, it is researched, evidence-based treatment that has shown a lot of effectiveness and promise in kids who are from age about 2 to about 7 years of age who are having a lot of disruptive behavior. So that is definitely a modality that you want to think about if that is something the child is struggling with. It can help with the behavioral component. It can also help the child kind of build rapport and connect with the parent as well. That's why it's so useful. And then secondly, in terms of the ADHD, now in this case, assuming he's a 6-year-old boy, ADHD is valid. In those cases, yes, medication could be considered as a first-line option. For kids who are 6 and under, and more importantly, behavioral therapy at times should be considered as a first-line treatment before you truly think about medications, because these are kids in general, whether 6 above or lower, they will need a lot of routine and a structure, consistency in place. And if the parent who already struggles with that, that is going to actually increase those ADHD symptoms and create more behavioral problems too.
Thank you, Dr. Khan and Dr. Smith and Nathan. So when this youth came to my court, his head was sunk low, I would say, just sad. It was obvious that he was sad. And 99% of the time, I ask the kids that come to my court, would you like, first of all, I get off the bench and I talk to them. And I always ask them, do you want a handshake, a high five, a fist bump, or a hug? And most of them want a fist bump or a high five. He wanted a hug. And so that's exactly what he got. And what was so amazing about this young boy was that he started talking about how sad he was. And of course, when we had our hearing, the very first question that I asked was, where is the therapy? Where were the non-pharmacological interventions that are supposed to be done before we just jump to the hospital? And there was none, obviously, that were given. And so the reality is just as all has already said, there's just sadness. There's sadness from being separated from his family, his siblings, and it's all illustrated by what was happening to him, the not sleeping, not eating, crying. It was very demonstrative in that regard, but no measures were taken. So what I did was I immediately started ordering sibling visits to occur in person weekly. I ordered that he was allowed to FaceTime his siblings twice a week in addition to that once a week visits. I had a conversation with the foster parents and I said, this is not our best practice. What can we do to help you and give you the tools to help him so he doesn't go back to the hospital? Because this is what's happening with him. And I also ordered that he receive trauma-informed therapy and that began within, I actually ordered it within 5 days. I was pretty amazed that it actually happened, but it's possible when you start reaching out to Superior. He received it. All his medications were removed and he was not hurting anybody. He's in school, doing great, and all is well, and was reunited with his siblings. So I think when we use trauma-informed practices inside the courtroom and how we work with kids and through court orders, that we have the ability to definitely make changes for children. Case study 3. 12-year-old recently placed in foster home. She was 2 grades behind in school, and she'd been fighting in school and having trouble doing her homework. So her psychological indicated her diagnosis was trauma due to neglect. Foster mom took her to a psychiatrist for evaluation, and based on foster mom's reporting, the youth was diagnosed with major depressive disorder and prescribed 3 medications. No counseling had occurred for this youth since she had been in care. And Dr. Smith, if you'll take just a few moments to talk about your thoughts about this.
So this is the refrain of this section is, again, where is the counseling and the trauma-informed care services that this child needs as far as an evidence-based treatment for her trauma? That was her diagnosis, right? And yet we have created a treatment plan that actually exists for a whole different diagnosis. The other thing I would point out, this comment about her being 2 grades behind in school and she's been fighting in school, does make me think that this is a child who, in addition to a psychological, may need further special education testing and neurodevelopmental testing to see whether she's got some intellectual disability or a learning disability going on, because not receiving appropriate therapy services for that in school may be contributing to that school failure and the behaviors at school.
Dr. Khan, just a few moments.
Yeah, so
what's your thoughts?
So in terms, I completely agree. That was my first thought in terms of her being 2 grades behind. She needs more testing done, not just from trauma perspective, but in terms of wanting to know, okay, does she have any limitations in terms of her processing things, working memory, anywhere else that the school is able to do those testings as well and provide her additional support to really help her succeed in an academic setting. The second thing is in terms of the medications for depression in particular, and even for the anxiety, the medications that are used commonly take about 4 to 6 weeks to work. They're not effective right away. So that's something I feel like the parents, the caregivers definitely need some education on those topics as well. And making sure that during the time period, an accurate assessment of the child is also provided. If the child is changing placements and the parent is not aware of how they typically look like as a normal functioning child, what is there to base on in terms of depression versus anxiety versus typically developing kid who may just have been traumatized in the past, and that's why he looks kind of this way. Nathan?
Yeah, just real quick. Because was trauma due to neglect, I would also question, was she even going to school, right? Was she having to get herself to school, that sort of thing, right? So again, put ourselves in her shoes. Plus, she's 12-year-old. Puberty alone is probably a reason everyone needs a psychotropic medication. No, I'm just kidding. But it is a tough age, and you add being in foster care on top of that, being behind an education. I mean, there's so many factors here that could contribute to this, but absolutely, again, where's the therapy? Why isn't that occurring? I would definitely push to have trauma-informed care therapy occurring, and would really want to take a hard look at those medications to see could she respond to trauma-informed care therapy without the need for the medication, or at least reducing that down maybe from 3 to 1, something of that nature. But again, on our end, look at the PMUR, get her set up with a therapist, that sort of thing.
Thank you, Nathan. And so just to conclude quickly with this particular youth, one of the things outside of the counseling and her coming and visiting with me, I did ask her ultimately the question about why she was fighting in school all the time. And her response is, because I'm mad. That was her answer. And so obviously the counseling needed to happen, but I also ordered that she receive tutoring. She is very ashamed that she was 2 grades behind due to her no fault of her own. So with that, I'm going to pass it back over to Nathan to close us out.
Thanks, Judge. So just real quickly, I know we're right at time. There's a whole lot of resources in your packet. We're not going to go over all of those today, but please take a look at them. It has contact information for several of us, as well as several other things related to trauma, understanding trauma, how you can look at those different pieces, that sort of thing. I do want to just quickly look. I know we had several questions that I believe have already been answered in the chat box. So let me just take a quick look and make sure we're not missing anything there. Let's see, and certainly, Nicole, if you see anything from the Q&A piece you want to highlight, please do. I'm just taking a quick read through of these right quick.
Sure. One of the questions was, were these modalities validated with BIPOC, Black, Indigenous Persons of Color, as part of these populations?
Yeah, so when we look at the modalities, what we typically use as the kind of the cornerstone for evaluation is we use the California Clearinghouse for child welfare. They tend to be the most uniform version. I do know that they take into effect some elements of culture. I do not know if every element you listed there is considered, but I do know the cultural piece is included in their review of that. I will just quickly say for TFCBT, for example, in particular, there are some different versions. There's a TFCBT version specific for Native American, for example. So yeah, you do want to think through, and we certainly look for those pieces as well. So when we're trying to match someone up to a therapist, that you look for, what gender, what culture the therapist is, things of that nature, to help the child be in the best situation possible.
And the last question was, what about the teen that refuses to take their meds and refuse to accept therapy and placements, most likely due to constant placements and trauma while in care? How can we encourage them or gain their trust?
I can take that.
Wow, yeah.
So I think that's a challenging situation. I agree, especially with the teenagers in particular. But my first question would be to ask them what their experience has been like with the medications, as well as therapy for that matter. And what are their concerns? A lot of times, kids will talk about not wanting to be dependent on the medications or worried about a particular side effects. They don't necessarily need the medications because they don't necessarily have any problems. And I think the latter one is the one where you have to be careful with, because those are the kids that will likely end up minimizing a lot of problems as well. So for that in particular, like a lot of times motivational interviewing can be very helpful, and talking to kids about their goals, their values and aspirations as well. And kind of using them as a guide to gain the trust of the child to engage in any sort of treatment, actually. In addition to that, building rapport, and that does not happen right away. You want to make sure that you're really learning about the child, the kid, or adolescent for the matter, in terms of their likes, their dislikes, their music, and likes in a sense that wanting to know in a sense is that not just ask them, but really show interest in it as well. If a child is really interested in sports, let's talk about his sports. Let's talk about, okay, what do they like about a particular team, a particular player, and things like that, and really build on those things in terms of what they can do as they grow up, whether they want to be an NFL player or a basketball player and so forth. But it is a challenging situation for sure. Go ahead.
Oh, does anyone else have anything to add on that?
Yeah, I'll just quickly add, because I think sometimes that question is, if someone's not responding to what's being asked of them, do they need to go to an RTC, right? I mean, you hear that kind of question, like, do we need to put them in a more strict environment? And I definitely agree with Dr. Khan, especially as you're thinking about your older teens, which is usually this group that's most resistant, is to really think through, what does that path look like for their exit from care? And are you setting them up to be more successful as they exit care? And so if they're highly resistant to this, and I know there are different regulations around even signing off on they took their medication and doing some of those things, but what I've seen to be the most effective is really to give them a voice and have them involved in their care, whether it's just giving them a little bit of oversight and letting them begin to take some of their medications, begin to be a part of scheduling some of those appointments, having some choice. Those things seem to prove most effective because, again, you're somewhat fighting upstream in that you want them to get to a place where they're going to make these choices on their own. And so the more you do to lay that foundation, the better your long-term outcome is going to be. In the short term, a lot of it is, it's short-term management. What are the little things the little levers you can push or access to figure out what's going to help motivate them? I completely agree with motivational interviewing. Let them guide you into where they're thinking and what's going to work for them. Get their input like, okay, well, what would you want or need to be willing to do these things that we're asking you to do? How could we make it work for you? That sort of thing. And they're still going to be difficult, but I can tell you, and Dr. Smith can elaborate, teenagers who aren't in foster care, they're going to be difficult too, right? So some of this is age appropriate, and you're going to have some of those same battles. So yeah, just one day at a time, keep moving it forward.
Well, thank you to each of our speakers and attendees. I'd like to remind everyone to please complete the evaluation at the end of this presentation. The conference will begin again tomorrow at 9:00 a.m. Thank you, everyone.
Thank you.
Thank you all.